Welcome listeners to Talking Eyes. I'm your host Leanne Trin, an optometrist and public health clinician based in Larrakia country, also known as Darwin, in the Northern Territory of Australia. This podcast was created to translate exciting innovative developments from vision research into a form that both clinicians and really any curious mind can understand. Innovation, simplicity, clarity. This series will be diving into a topic where the research has been absolutely awe-inspiring. The retina. It's just a small part of the human eye, roughly the size of a postage stamp, but it's an incredible piece of human biology that plays a central role in how we experience the world around us.
The retina can get damaged from bleeding and leaking fluid inside the eyes. When that happens, it's like having a burst water pipe under the floorboards of your house. When the fluid clears or the leakage clears, sometimes the damage can still be evident and permanent.
Today's episode in this series of Talking Retina covers the leading cause of vision loss in those aged over 50, macular degeneration. This episode has been crafted especially for our community-based clinicians who may have people presenting with a family history of macular degeneration, and these people might be reporting symptoms of vision loss in their central field of view. To discuss macular degeneration, or AMD as it is commonly called now, I'm so delighted to welcome Professor Robyn Guymer to our show. Robyn is the Deputy Director of the Centre for Eye Research Australia and a clinician scientist who has spearheaded research in this field in Australia and internationally, really, for roughly 3 decades. Welcome, Robyn.
Thanks very much. Great to be here.
Robyn, now correct me if I require it, but my understanding of your career is that you took a number of years after finishing your medical degree in the late 80s to decide what sort of doctor you wanted to be. You completed a PhD at the Walter and Eliza Hall Research Institute in immunology, and you eventually settled on becoming an eye specialist, an ophthalmologist, with the intention of returning to your regional home of Shepparton to provide care there. Has that happened at all?
No, that didn't happen. That was the plan when I left to do a fellowship at Moorfields in London, and I did 2 fellowships, one in medical retina and one in ocular plastics, which I did in Salisbury. And during really the first one in medical retina, it became quite clear that age-related macular degeneration was a disease where people would come and really there was nothing that we could offer them. And so it was really during that time I thought it's an excellent disease that you could research. You could potentially make more impact by, rather than seeing a certain number of patients and telling them thank you for coming but come back when the other eye has a problem, which it often did. It would be better to spend the time trying to research the cause and then the treatment of AMD. So I changed my mind during the fellowship.
How were you treating AMD at that point?
So this was the mid-1990s. The only treatment we had was for wet AMD or neovascular AMD when it was what's called classic, so where it was very well defined and not at the fovea. So, and the treatment was laser. So the idea was that if you could laser and sort of cauterize the bleeding blood vessel, you would save central vision. But most people present it when it was already under the middle, or they present it with what was called occult, which weren't well defined, so you couldn't actually identify the area that you needed to laser. And so very few people could actually take advantage of that treatment. And indeed, you often made them worse initially, knowing that in a few years they would be better, but that's a very hard thing to sell to a patient, that I'm going to make you worse now, give you a scotoma, but believe me, in a few years' time you'll be better off. So it was a very awkward thing to have to do. So apart from that, there really was no treatment for the late stages of AMD.
Yeah, right. Robyn, I'd like us to start this segment discussing the experience of people affected by AMD. As a clinician, we understand it's macular degeneration, so theoretically we know that it will affect a person's central vision, their high acuity vision, because it affects this area of the retina that's so densely packed with photoreceptors. I'll often describe the condition to my own patients as affecting their high-resolution central vision, and things like reading and recognising people's faces will become more difficult. But beyond this, how are people with AMD challenged?
So I think the first thing is that often they will have looked after a parent that had AMD and have had to care for them when they've had quite poor central vision, remembering this would have been in times when we didn't have treatments. So there's already anxiety and real concern of as what does it mean for them. So even early on when they don't have symptoms, they've been diagnosed perhaps by optometrists when they go for their glasses. There are still some anxieties around, what does it mean and what do you mean you can't fix it? Like why can't you do something to stop it? And so I think those initial conversations are often around monitoring vision with the Amsler grid, unfortunately, to try and pick up the one thing we can treat, which is this wet AMD. And the earlier you pick it up, the better. So we're still with the Amsler grid, but primarily the concept is to monitor one eye at a time to pick up the first signs of wet AMD in the hope that if we catch it early, we'll get a better outcome. Yeah. And then as you say, what the textbooks say and what is true is it's reading, driving, and recognising faces. The first thing that actually happens probably before they lose driving vision is this difficulty reading. So they can still read, but it's just not pleasurable. So they don't necessarily want to pick up a novel and read it, but they can still read the recipes or the bills. And so there's this first step is to try and get onto talking books or an iPad where you can enlarge the print. So they're already perhaps much earlier than the late stage of the disease, they're having some issues with reading. And then I think driving is the thing that impacts greatly and people that, they're anxious to hang on to that driving vision and yet you tell them that maybe you'll pass this time, but, try and put processes in place because next time the likelihood is that you won't. So we're just sort of delaying the inevitable. And there's many people that don't live where there's public transport. They're reliant upon others to get them places and they really don't like that because also these people are getting older and all their things that they like to do and their independence is being challenged in many ways. And so here's just another one where they're used to going to golf. Now they're going to have to ask someone to take them. They can't go to the shops when they normally would. They can't go to church, whatever. So it's that loss of independence that comes with the change in vision that is a big impact on the patient.
Yeah, and I've noticed as well when I was speaking to somebody who had not macular degeneration but another condition, central serous retinopathy in one eye, where we assume that the central vision of one eye has been affected, but she spoke about her loss of confidence with driving specifically. So even though, she could see well enough by our standards to drive, she had this sense of a loss of confidence already.
Yes, you certainly need two good eyes for depth perception. And so even if you do pass the driving test and are like legally allowed to drive, it's still not, I tell people you're legal, but that doesn't necessarily mean you're safe because that lack of depth perception means that if you're in a narrow road, you often can't judge how close you are to the car next to you. So, yeah, even though you strictly speaking meet the criteria, it doesn't mean that you can do as good as a normally sighted person.
And I was surprised actually to find that nyctalopia, so sort of night blindness, can be associated with AMD also.
So it's actually a very early symptom. It's not necessarily night blindness, but the difficulty to adjust to the dark. So they actually can see in the dark. It just takes them much longer, particularly with a certain sort of AMD that has this new deposit called reticular pseudodrusen. So those people have great difficulty in adjusting to different lighting conditions. And so that manifests in probably difficulty in driving at night because then they're not adapted to the dark and so they find it more difficult. But more importantly is driving during the day and then going into the tunnel or going into an underground car park. They're actually blinded. You know how when you go to the picture theatre it might take you 10 minutes to see as good as you're going to see? Well, some of these people will take till tomorrow to see. So they'll get there, but it just takes them a long time. So you can imagine driving and then suddenly going into the tunnel. No wonder people slow down. And so other things that they say that they can't do is when they put their alarm on, they go shopping and they come back. When they come back indoors, they can't see their alarm. So it's just really that delayed dark adaptation rather than actual night blindness.
Yeah. And there's a few risk factors that we've identified that are really strongly correlated to macular degeneration. Can we go through them?
Yeah. So the first one's age. The biggest risk factor is age, but there's not much at the moment you can do about that.
About ageing.
Yeah. So there are now some strategies coming to slow, this biological aging versus chronological aging. So there is progress on reversing aging, but at the moment you can't really do much about that. So aging and genetics. So AMD was one of the very first what's called complex chronic diseases that had the genetic risk factors identified. And this is now 2005. And so now there are many little differences in one's DNA that put you at greater or lesser risk. So those two things combined, again, are things at the moment you can't alter. Potentially you can do something with your genetics down the track as well. But traditionally they are non-modifiable risk factors. And in terms of modifiable risk factors, smoking still remains the top one and certainly something you can do something about. And then we get into more murky areas as to what's proven and what isn't. But I think that there's certainly stronger data now on the Mediterranean diet. And certainly it seems that you can somewhat reverse your genetic risk by eating well. And BMI comes into this. And like everything with aging, exercise, good diet, good weight are all things that seem to be useful in someone with AMD. Whether they can specifically change that risk significantly is another thing.
Right. So the evidence behind that is fairly low, would you say?
I think the Mediterranean diet is more recently becoming more strong, but things like sunlight, exercise, red wine, all that, red meat, all those things. There are certainly papers that suggest there are good and bad things to eat, but it's not necessarily reproduced in every study.
A burgeoning area of business in this day and age seems to be nutrient supplementation. I'll go into this a bit more in our nutrition episode, but there seems to be quite high demand for a magic pill or maybe 10, evidenced by the entire aisle at local pharmacy giants befuddling people with their products. Omega-3 supplementation seems to be something popular and somewhat eye-related. Is there robust evidence behind limiting your omega-6s and
so
increasing your omega-3s?
Omega-6 is thought to be pro-inflammatory and omega-3 not inflammatory, and so it makes sense that perhaps omega-3s might help. And omega-3s is also considered to be useful perhaps in Alzheimer's disease prevention. But when the ARIDS people did a large study where they looked at omega-3s, they found really no benefit. So there's no strong evidence in that study, at least. I don't know of any studies suggesting omega-6, and in my mind it seems counterintuitive given that it's a pro-inflammatory molecule. But I do know that they sell margarine and butter that's got omega-6, and I just can't really work that out myself. So I think at the moment there's no strong evidence towards either of those, but if I was going to take something, it would be omega-3, potentially for other diseases as well as AMD.
In this next part, I want to talk about the traditional diagnosis and treatment methods. And you alluded to earlier that traditionally we labelled AMD as either wet or dry, and they're terms which are still frequently used today. I guess there's a real simplicity about using a binary term to describe a condition. You know, either one type of condition we can treat really effectively, and the other type we're still developing treatments for. But I'd like to discuss diagnosis because when I was looking into the research around diagnosis, there has been so much research conducted into simply classifying the condition. And there's so much importance behind being able to classify a condition correctly, particularly now when novel treatments are in clinical trials and also different treatments becoming available in order to treat the condition at different stages. There was a Beckman classification initiative that was formed over a decade ago, and that was working towards an international consensus for the description of macular degeneration. Was consensus achieved?
Yep. This is a really important thing to talk about, so I'm glad that you brought it up. And I don't think I've ever classified AMD as having only two forms, wet and dry. So wet and dry are the late forms of AMD, but AMD we know presents with drusen. So AMD is defined by the presence of drusen. And the Beckman classification, we all got together and did this Delphi consensus sort of exercise, was just to try and get the world to use a very simple classification so we all talk the same language. Unfortunately, a decade on, still not the case. But the point of the Beckman was to use just colour fundus photography or your own examination to be able to come up with a classification system. And it's based on the ARIDS population-based studies that show that there is early and intermediate and late AMD. They're the classifications. And the difference between early and intermediate is the size of the drusen, because the size of the drusen or the drusen volume, the amount of drusen material that you have, increases the risk of progression to late. So I would love for us all to call AMD based on the Beckman classification as normal, early, intermediate and late. There was something called normal aging change, which gets rid of the hard drusen. The drusen less than 63 micron was not thought in and of themselves to increase the risk substantially. So we took it out of the diagnosis of AMD. We thought a 5% increased risk wasn't enough to tell someone they had AMD. So hard drusen became normal aging change. It doesn't actually give you a diagnosis of AMD. Drusen greater than 63 microns becomes early AMD. If it's greater than 125, it becomes intermediate, and there's some pigment classifications in there as well. But so then you if you progress to what's called vision-threatening late-stage AMD, you either have wet and dry. And to me, wet and dry is the terms that you would use for the lay community. It is not terms that we would use, hopefully, amongst ourselves, nor in the literature. We should use neovascular AMD and we should use geographic atrophy. They are the scientific terms for what we call wet and dry. Unfortunately, many people, particularly the Americans, call everything that's not wet dry. And this becomes problematic now when we have treatments, or we will soon have treatments in Australia for the late form of dry AMD, geographic atrophy. Yet you'll read papers, you'll hear talks of early dry, late dry, or just dry, and you've got no idea what they mean by dry, whereas the rest of us think that dry AMD means geographic atrophy, a vision-threatening late-stage complication of these drusen. So I would totally recommend that everyone adopt the Beckman classification. It was meant to not be based on multimodal imaging. You don't need sophisticated equipment to do autofluorescence. It's just a simple way that we can all talk the same language. And unfortunately, a decade on, we haven't all adopted that.
Really important point here that we'd like to emphasise to our clinicians. If you're not across this Beckman classification, get on it. Within the Beckman classification system, we have, like you mentioned, early, intermediate, late. Do they have corresponding symptomatic changes, or is it just based on clinical signs?
So it's based on risk of progression. So that the difference between why bother calling something early and intermediate was based on the risk of progression. So this goes back to the ARID simple classification where they had, if you've got one large drusen, you get 1 point. If you've got it in both eyes, you get 2 points. If you've got pigmentary abnormalities, you get a point. So you got up to 4 points, and that increased your risk. So if you had 4 things, large drusen plus pigment in both eyes, your risk of progression to late vision-threatening AMD was 50% in 5 years. And so the classification system of early and intermediate and putting those hard drusen people in the normal aging was based on what is your risk of progression to vision-threatening late AMD in 5 years. In terms of the symptoms, it pretty much depends on where. So if you've got late AMD, you may have no symptoms if it's not near the fovea. And that's becomes a big problem when we look at geographic atrophy. If it's not under the fovea, which it most often isn't, patients may be totally unaware of it.
Yeah. And so this classification is also important in terms of management as well, isn't it? The advice that we provide to patients. So if we're seeing somebody with early macular degeneration, what sort of advice would you be giving to patients at that point?
Yeah, so I guess there's not that much difference between early and intermediate, only perhaps the gravity of which you use your voice to tell people what they need to do. But all those things we talked about for risk factors, certainly people should try and stop smoking. They should optimize their diet, exercise, keep a good weight. A lot of people give supplements, the ARID supplements or a version of the ARID supplements, and there is different views as to how valuable they are.
What's your view, Robyn?
So I would much prefer someone eat a healthy diet and do the exercise and all that sort of stuff. If someone is on a supplement, I won't necessarily stop it, but I'm not convinced that the evidence is strong enough to take the ARID supplement, and there are some risks. So I see patients that are on, if some is enough, some is good, then more is better, and so then they run into side effects of taking too much zinc, or they get anemic because the zinc binds their hemoglobin, and then they're being chased with colonoscopies and things because they haven't bothered to tell their GP they're on supplements. And then they take other supplements as well, and then they sometimes have some side effects. So they're not without some associations, particularly if you don't follow the instructions and take as instructed. So I don't have a strong opinion to take them, and if someone wants to take them, then I'm happy that they do that. The most important thing for the people with the drusen is to give the Amsler grid. And so not only do you give the lifestyle advice, but you need them to monitor their vision. Because at the moment, the only thing that we can treat effectively is neovascular AMD, and the earlier you get it, the better. So that's even more important now than ever to give the Amsler grid, explain that the importance is you have to do one eye at a time. There's nothing special about the grid. I don't mind if people use the picture frame, tiles in the bathroom, Venetian blinds. The whole idea of the Amsler grid was to prompt you to check one eye and the other, because people don't necessarily notice wet AMD in one eye if the other eye is fine. So once a week, get into the habit of checking the Amsler grid for profound change that's consistent, that's there this day and the next day. And important not to tell them that it's not like is it or isn't it, I'm not sure. You get used to what it looks like, and then every week you do it, and if suddenly one day it's different, then that's when you act. It's not, I'm not sure, I better go ring up again. And so that person unfortunately spends their life, worrying and getting checked more often than they need. So the Amsler grid is very important, and you can get it now as apps, and you don't have to have the piece of paper. And ultimately, we would hope to have something a bit more sophisticated to the Amsler grid, because the problem with the Amsler grid is you're asking people to do it for 5, 10, 15, 20 years, and every day they do it, it's the same, and they don't understand why they have to keep doing it, and then they don't do it. So that's the main problem with any self-monitoring, is that they don't tend to do it for more than a couple of months. So we need more sophisticated ways to engage patients to check their vision. So that's the early intermediate stage. And then by late stage, well, it's clearly if you're worried about the onset of neovascular AMD, they need to go urgently to see a retinal specialist or a general ophthalmologist, perhaps if they treat wet AMD. And now we're getting into an era of potentially treatments for geographic atrophy.
So just to recap, the distortion, the blurred vision, dark spots, scotomas, these are all symptoms of the changes occurring at the choroid, where new blood vessels forming are fragile, they're leaky, and then disruptive to that perfect arrangement of those photoreceptor cells that this choroid tissue is feeding. The earlier this leaking can be detected, and self-monitoring with the Amsler grid is what we have at the moment to support this, the better the visual prognosis. Robyn, you spoke about laser earlier, thermal laser, designed to seal all those naughty new blood vessels causing the disruption to vision. But at the same time, it takes out some of those good photoreceptors we want to preserve. Fortunately, we have this incredible new treatment now, anti-VEGF injections, which has been a real game changer in this treatment space, hasn't it, Robyn?
Yeah, absolutely. It's sort of like a miracle in our time, really. So before that we knew that the vision loss was inevitable and profound. And now if you get early enough before there's scarring that's not reversible, then you should be able to at least keep the vision as it is when they walked in the door. And certainly all the trials show, quite significant improvement in vision in the short term. Our problem now is mainly in the longer term, the 3, 4, 5 years, we're still losing vision primarily from atrophy or fibrosis. The anti-VEGF part, the non-leaking blood vessel part, really works quite well, and we now have 3 or 4 different choices of drug. So the early good control of the blood vessel leaking is pretty well under control, but we haven't cured the underlying problem as to why this happened. And if it's the RPE cells that are unwell, then they're going to degenerate further, and then it's going to lead to photoreceptor death, and then we're going to get atrophy. And if there is some leak, we're going to get a little bit of fibrosis. So they're the things we haven't got on top of yet, but there's a lot of interest in addition to the anti-VEGF, what else do we have to give to try and keep that 3, 4, 5, 6, onward vision. But in general, it's been a miracle in that we've prevented that sudden, profound, significant loss of vision. But can I also say that things become a bit more complicated. So when you're looking at neovascular AMD, you note I didn't say exudative AMD, because now within neovascular AMD there are two forms. One is the ones that leak, the wet ones, called exudative neovascular AMD. But now the more you look, particularly on OCT angiography, you can find people with non-exudative neovascular disease. So new vessels are there. They're not causing any trouble. They're probably there helping stopping atrophy, but they do increase the risk of them exuding, then becoming wet AMD that you need to treat. And I guess this is a little bit of a problem that we see. Many people get sent straight to casualty for sort of an incidental finding on OCT scan in optometry, where OCT scan's done, there's no symptoms, but there's this little bit of fluid. And then they get rushed in and then often get treated for wet AMD when actually they may just have had one of these non-exudative ones with a little bit of a gap. And so it's become quite complicated to define exudative neovascular AMD that requires treatment. And oftentimes it's not necessary if it's a incidental finding when you go to the optometrist, but we're having to deal with those cases that come in, and if you're not careful, they end up on a treatment for forever regimen.
Mm. And then the other type of late AMD, I know, again, there's some incredible work going behind the scenes just to classify the geographic atrophy. There's the International CAM group, Consensus on Atrophy meeting. What an incredibly micro view that a meeting consensus needs to take on this. How did this group get established, and why is it important in this case?
Yeah. So traditionally geographic atrophy is defined on a coloured fundus photo. It's a hypopigmented, sharply defined area with a choroidal vessel in its base. More recently, we've been using fundus autofluorescent images to define geographic atrophy because the atrophy is black compared to like a whitish grey where the retina is normal. And it's black because there's no retinal pigment epithelium, which is the thing that has the lipofuscin that causes the autofluorescence. So fundus autofluorescence imaging has become pretty much the standard for defining the area of geographic atrophy. And in all the trials, you'll see that people actually bother to outline all the areas of geographic atrophy based on the fundus autofluorescence. But we all know that you can see on an OCT scan the beginnings that cells are dying long before you actually can see this black hole, or on the colour fundus photo, an orange hole. And so the next form of classification will be, how do you detect the very earliest signs that cells are dying, because you would like to intervene much earlier than waiting for these holes to try to slow down the growth. And so at the moment, all the treatments are you have to have a hole on your autofluorescence. It has to be a certain size. It can't be too big, can't be too small. And you're trying to slow down the growth. but all of us would like to start earlier. So the idea is, well, on an OCT scan then, what do you see that is the corollary of atrophy? And so we actually 10 years ago described what's called nascent geographic atrophy. It was done by my PhD student at the time, Ziwu, who was an optometrist, and he's still with us doing wonderful work in trying to help with these classifications. But we found that these changes on an OCT predicted the progression to geographic atrophy. So we called it nascent geographic atrophy, meaning the beginnings. You wouldn't see it on a colour photo. It would still be in intermediate AMD in terms of the Beckman classification, but within intermediate AMD, there are people with signs on the OCT that the photoreceptors and RPE are not there. It's just not big enough that you would see it on the colour fundus photo. So they're still called intermediate AMD, but they're at the riskier end because you can already see the beginnings that the cells are dead. And so it's really, so we defined what we thought was our best indication that cells were on the way out and you were going to get atrophy. And indeed, the hazards ratio of getting atrophy in 3 years, having had this nascent GA, is like 78. So it's like profound. It's like huge. Smoking is like 2 for progression. So if you see these early OCT signs, we have said in the literature that it predicts progression to GA. So then the classification of atrophy group really started a few years later and actually used all our data, all our imaging, because not many people have longitudinal natural history on people with intermediate AMD, because why would you? But it was part of our research looking at a treatment for intermediate AMD. So the natural history arm has become extraordinarily important around the world for people to look at and determine in their own minds what are the preceding changes that get to atrophy. And so because it's a consensus, you have to agree with people, even though you may not. So at the end of the classification of atrophy meetings, it was determined that there were slight subtleties in what you see on an OCT that predicts progression. And basically it was related to what are the layers of the OCT that are missing. So, for example, this classification called RPE and outer retinal atrophy meant that at the beginnings of atrophy, the RPE is either attenuated or disrupted, and then the outer retina is the photoreceptor. So all the lines that indicate the photoreceptors on the OCT, they are implicated. So it was trying to use terms to describe what you would see on the OCT without any knowledge of what was the progression. So it was just a group of people in a room looking actually at our slides, our OCTs from our natural history study, and coming up with this classification of complete RPE and outer retinal atrophy, or CRORA, and it had to be an area that was a length that was 250 microns. So if you had 250 microns of seeing the signal going through, so it's called hypertransmission into the choroid, seeing the RPE that was disrupted or attenuated, and seeing loss of one or other of the lines that indicate the photoreceptors, so the ellipsoid zone or the external limiting membrane, or this subsidence that we had described as part of nascent GA. So if you had those, you have complete RP and outer retinal atrophy. And we'd actually published as part of this CAM that you could feel free to call that you see on the OCT geographic atrophy. So it was the OCT equivalent to what you were seeing on the colour. It turns out it isn't. It's often an earlier feature, and so we will change some of the definition of this CRORA in the next publication. But I guess the take-home message is you can see on an OCT features that give you the distinct impression that this person is on the way to geographic atrophy. And why that's important is if there's treatments for geographic atrophy, perhaps they're the people that you need to refer on, or at least warn them that they're at the further end of intermediate AMD and that these treatments may well be relevant to them in the not too distant future.
Can we talk about the treatment for geographic atrophy? Because that's something that's quite new.
Mm-hmm. So it would be easy if we knew the cause of AMD, because then you could concentrate on one treatment. But we don't know the cause of AMD still, which is embarrassing. But there are many pathways that could be implicated. And so there are many trials currently underway, all picking different parts, different pathways. Could be oxidative stress, could be accumulation of toxic byproducts of the retinal cycle, could be choroidal insufficiency, so cardiovascular disease, a whole range of things. But if you look at the genetics certainly pointed to this complement pathway. And so the vast majority of trials and the 2 drugs that have been approved to date in America are based on blocking complement activation, and complement has to do with inflammation. So this concept that AMD is either due to or at least made worse by ongoing unchecked inflammation in the retina. And so the plan is to block the complement pathway, which is the thing that brings about this inflammation. And so there are many studies sort of trying to block the complement pathway at various spots along the way. And the first 2 treatments are given by intravitreal injections, either every month or every other month for forever, of drugs that block. So the first one blocks complement factor 3 and the second one blocks complement factor 5. So there would be sophisticated answers as to why blocking one might be better than the other, but basically they block this system from causing unchecked inflammation. And the studies show that you can slow down the growth of that atrophy. So that hole that we measured on the autofluorescence, if you give this drug every month or every other month, you can slow down the growth of that hole.
So it really requires geographic atrophy to have been diagnosed before.
Correct. All the studies to date require a certain size. It has to be a size that can reproducibly be measured. So it has to be bigger than what you would hope it to be. And if it's multifocal, then you have to have one lesion that's a certain size. And the trials differ a little, but basically, yes, you have to have patches missing. And the whole point is to try and slow down the growth of those holes to try and reduce the risk of it getting to the fovea. So the way to think about it really is sort of a survival curve. Can I keep you reading for another year or another 2 years? Because unfortunately, the trials to date have not shown an improvement of vision. There's no difference between the treatment and the control group in terms of visual acuity. And the trials were run over 1 to 2 years. But the belief is that if they're slowing down the cells from dying, at some point, 3 or 4 years, you're going to have better vision. But unfortunately, the trials were too short to actually show that, which is problematic in getting approval. But if the way to think about it is, even though there was no change in vision, you're aiming to slow down the growth to give you a longer time where you've got your foveal vision, because usually AMD starts in the perifoveal area. It doesn't usually start in the middle. And so it's really about time to death of those foveal cells. Can I give you another year, another 2 years of reading, driving?
Slowing down that progression of vision loss towards that really fine central vision.
Correct. Although the studies weren't able to show that was possible, and that's caused some problems with getting approval outside America.
What allows us to approve a drug like that then? What are the criteria?
Yeah, so the criteria are different in different jurisdictions. So in America, there's 2 drugs that do slow down the growth of the holes, and they've been approved. And so the thinking there is, well, if you can save cells from dying, that's got to be a good thing. Even though you haven't shown that the vision is better, surely it's a good thing to stop cells from dying. And if you can do some sophisticated functional tests, which are called microperimetry, it was what was called a post hoc analysis. So it wasn't part of the planned analysis, but when they went back and had a look, you could actually see that we were keeping the visual function around the holes better in the treatment group. But if you can imagine, if the hole is not the fovea, it can grow and the patient may notice no difference. So then the problem then is, why would you inject someone who's 90 every month and they don't notice a difference? And then the argument is, well, if you wait long enough, she will notice the difference. So, but then it's a toss-up between, is she going to die before she notices the difference? And herein lies the problem. But the FDA did not require to show a functional benefit for the patient. It just required us to show that the cells were living longer. Whereas the Europeans say, well, I want to know that having gone through that treatment, the patient actually is better off. And so you can show all these post hoc analysis where the number of scotometers points are less, the function around the area is better, but actually the patient in the tests that we have today did not see any better. So we have to, it's not necessarily that the drug didn't work, we just have to come up with better tests to be able to prove that actually the patient is better off.
The treatment is only when geographic atrophy has appeared. Is it not effective when we see those precursor signs like the nascent geographic atrophy that you...
So all the trials have to be able to prove that it works. So they had to have in a certain size of atrophy that you could reproducibly measure in a reading centre, and just happened to be a particular size, half a disc area. So the only evidence that we have is when you start at that point. Of course, we think you would want to start earlier. The problem is, would you really start with someone with intermediate AMD that has these precursor signs on the OCT, that has no functional problem, and you're going to tell them they need an intravitreal injection every month for the rest of their life at great cost and at some risk? And so the thing that's become, so maybe you can convince somebody because they've lost vision in one eye and they know what's happening, and you show them the pictures every year and they can see it getting closer and closer to the fovea. And you go, sure, I'm up for that because I know what happened to the other eye. The problem is that just recently in the US, when they're using these drugs in the real world, particularly the first one, pegcetacoplan, there's been just a few very nasty outcomes with some inflammatory side effects that cause vasculitis and death of the retina, and the patients ended up worse off. So now you have to convince the patient that not only are they having the injections every month and they're not going to notice a change for a few years, but there's this small risk, very small risk, that they could be worse off. So would you really want to do that early on when they've got intermediate AMD? So what we really need is not a treatment it's not going to be a monthly injection in your eye ultimately to treat geographic atrophy. We have to start with this. But there are treatments now that are trials that are in oral, subcutaneous injections, stem cells. There is gene therapy, which would be a one-off treatment. So there's all these other ways to potentially slow down cell death. And whilst it's a great first step to have something to offer a patient, if indeed it were approved in Australia, it's obviously not the end game. But we do have to start somewhere. And with neovascular AMD, we started with a drug that we don't even use now. So small steps, getting used to, patients used to knowing about AMD, geographic atrophy, optometrist upskilling and being able to identify geographic atrophy and risk factors for progression. And so all those things are valuable. And there will be patients that are prepared to want to do that treatment because they can see the consequences, particularly to their other eye, or they see every year that they're getting worse. But there's 10, at least almost a dozen, I think, trials, even more, in geographic atrophy currently. So we're right at the beginning of our era where we'll be able to treat geographic atrophy and earlier. And that's the exciting thing, because treating earlier obviously means that there'll be more vision available potentially to people, to individuals. Can we talk about some prognostic biomarkers to understand the risk of progression? And I know I read about a nanosecond laser intervention that you guys have been working on, and how effective it was, particularly for people with reticular pseudodrusen. Mm-hmm. Can you talk about that? Yep. So I guess that's two different questions. One is, if you see someone with GA, can you tell which ones are going to grow fast or not? And yes, there are studies now that tell us predictors of progression. So, for example, multifocal lesions grow faster than unifocal lesions. Lesions at the fovea grow slower than lesions just away from the fovea. Age grow faster with age. Reticular pseudodrusen is a risk factor that seems to be associated with faster growth, and that the growth would go towards the reticular pseudodrusen. So they are some of the risk factors for GA growth. Second question is, so is there anybody that's trying to treat intermediate AMD and stop progression? So certainly that's where we've been interested for forever, is trying to intervene earlier. And so there's an Australian-made laser called a nanosecond laser, and we did a study now 10 years ago where we recruited people with intermediate AMD but without nascent geographic atrophy, because we wanted to see if we could slow the progression to that earliest stage of atrophy. And in that study, we really found no difference between those with and without the treatment. However, at the time, we were learning about these reticular pseudodrusen that seemed to imply very sick cells, very sick RPE. They're very bad news. So given that the laser is aimed at the RPE to try and rejuvenate the RPE, the question I posed was, maybe those people with reticular pseudodrusen were too far down a track. We just could not influence their outcome. And so when we looked at the laser, again, post hoc, so it's not like statistically valid, but if you look post hoc at only those that did not have reticular pseudodrusen, the laser did remarkably well. It slowed the progression fourfold. And those with reticular pseudodrusen, it seemed to probably make them worse. Although, again, neither are proven because it was this post hoc analysis, which has problems statistically because you haven't randomized on the basis of those characteristics. So we're very keen to do another study without reticular pseudodrusen patients in them. A big European study with the company is trying to raise capital to do that study so that we can reproduce what we found in what was called the LEAD study. But definitely at the moment, no authority would allow us to include people with reticular pseudodrusen, which are the higher risk people, because of that suggestion that we may have made them at least not better, but possibly even worse.
Can we just briefly discuss the difference between the origins, perhaps even of normal drusen that we would normally see and reticular pseudodrusen?
That's a good question because it's not easy to identify reticular pseudodrusen. So drusen, conventional drusen, are under the RPE. And so when you're looking on your OCT scan, the best way to identify the difference is on the OCT. So what you're looking for is where the RPE is, and if there's deposit under the RPE, they're conventional drusen. Again, we don't really know the cause of drusen or reticular pseudodrusen for that matter, but so all we're doing really is identifying deposits in different locations. And on a colour photo, you often miss these reticular pseudodrusen, which is why people really hadn't paid much attention to them. You miss more than 50%. So on a colour photo, they may actually be misinterpreted for hard drusen. They're little yellow spots. So the best way to look for them is on OCT, and then try to validate their appearance on an autofluorescence or an infrared on fast image. And they're often in beautiful clusters and they're all interspaced equally, and that's why they're called reticular. It's like a net. Reticular means net-like. And so you really would like to see this pattern, which is on OCT confirmed as having deposits now above the RPE. So conventional drusen is below the RPE, reticular pseudodrusen are above the RPE. And they look often different. They're more like haystacks, they're more pointy, there's different stages. There's stage 3 one, it goes through the EZ, ELM and into the sort of more to the middle of the OCT. And so we don't know what the implication of those different stages are. Stage 2 is where you see this sort of wobbly EZ ellipsoid zone because underneath is this deposits, very evenly spaced again. And it's not easy to actually identify. And so we've been actually busy trying to make an algorithm. So we have a very nice algorithm that should be published soon where eventually you'll be able to, it's be open source, you'll be able to run your OCT through this algorithm and you'll be able to determine whether or not you think there's reticular pseudodrusen, because going on the basis of the laser study, there may well be different treatments for those with and without reticular pseudodrusen. So it will become important for everyone to be able to know the difference. But it's not easy, and we need to learn and get familiar with looking for them, because if nothing else, they are a risk factor for more rapid progression of geographic atrophy.
And does that mean we should be monitoring much more closely as well then?
So there probably is an increased risk of wet AMD. So that the whole conversation, if you find someone with reticular pseudodrusen, perhaps you're a bit more firm that they need to do the Amsler grid. At the moment, there's no particular treatment. So I don't know that you really need to monitor them more closely other than they are more at risk of GA. And when we do have GA treatments, they may be the ones that will get there quicker. So I still think probably yearly for people with intermediate AMD, but just note that they have this slightly higher risk characteristic.
What are the minimum requirements you think in primary eye care to adequately diagnose and differentiate macular degeneration?
It's a talking point as well, because we've been trying to write the RANSCO collaborative guidelines for referral, and there's a big discussion as to whether we should expect people to have an OCT if they're managing people with AMD, and which is a big ask for people remotely and rurally. Maybe they don't have OCTs, but I do think we're getting to a point where you really can't adequately stage AMD or understand the risk factors without an OCT. So I think minimum criteria is to examine the patient and an OCT to get to the essence of their risk, basically.
Yep. So OCT, seeing what their monitoring their visual acuity, giving them an AMSLA grid.
Yep.
Those are the three.
Yep. Lifestyle advice. And then autofluorescence for a treating clinician will be important, because that's the thing that you will measure the size of the atrophy on, and you'll be able to show a patient over time, look, this is your growth rate, this is what it was. So what we're asking for at the moment is for people who see geographic atrophy, if you could do the autofluorescence images now, then when they come back, when the treatments are approved, we'll have some idea of growth rate, because people do differ. And so you would want to be able to show a patient, look, in the last year, you really haven't changed much. Maybe we don't have to intervene for you. And then the next patient, goodness me, you've grown 2 millimeters squared a year. You're a fast progressor. We really should start now. So my call would be, if you do have fundus autofluorescence, please do that on your geographic atrophy patients, so that then in a year's time or 6 months' time, when they now want to know about treatment, we'll have some natural history on each individual patient to be able to guide them much better than just giving them the average growth rates.
You mentioned at the beginning about dark adaptation and how people with AMD can have difficulty. Is that something that we could potentially be testing to define what sort of stage of AMD they're at in terms of cellular loss?
Yes, so dark adaptation is a great test for identifying the first defects in early and intermediate AMD, which primarily are people with reticular pseudodrusen. However, patients hate dark adaptation tests. It takes a long time. You have to make sure that they're adapted out of the, they've come in the summer, they've come into your room, you've got a dark adaptation. It's a hard test to do. So the consensus is that it's not something that you could do clinically. And even in research trials, people really don't like having to do dark adaptation or just a rod test. And so again, at the moment, I don't know that it will necessarily indicate those at greatest risk. It's more likely that they will have the reticular pseudodrusen, and the reticular pseudodrusen will indicate that risk. So the hope is in all these functional tests, we'll get a structural correlate so that everyone else doesn't have to do the function.
Yeah.
So once we tell you that this is the new way to define geographic atrophy because it's based on a deep scotoma that's reproducible, and that's the end of a trial of intermediate AMD, then you won't have to all do that. We'll say once the OCT looks like this, that's enough to define what we know the function usually is in this case. So I'm hopeful that we don't end up having to do dark adaptation or even mesopic microperimetry clinically. They're more sort of research tools.
Sounds highly impractical, and I know people hate doing visual fields testing. They hate doing hearing tests. Any sort of threshold testing is very much disliked. So I can see that is completely not practical whatsoever, and having objective correlates would be a really great thing. Emerging treatment approaches. So one of the really important things for staging is identifying people who might be suitable for these emerging treatments that are in clinical trials at the moment for AMD. Are there any emerging treatments that we will see over the next 5 to 10 years for the different stages? And what sort of things should we be looking out for right now, Robyn?
So the current trials that are recruiting, so again, if people have patients that may be interested in trials, please send them to trial recruitment sites. But interesting things are, for example, there's a tablet that can slow down the visual cycle in the effort to reduce the toxic byproducts is one strategy. So that would be handy if you had a tablet, and then that would treat both eyes at once. There's a couple of trials with subcutaneous injections that patients do at home themselves that, again, would be bilateral. But particularly if you're targeting the complement pathway, the problem is that you need the complement pathway to fight infection. So if you're going to do something systemically, you run into risks of increasing infections. And so in those trials, we have to make sure everyone is vaccinated to every conceivable disease that they could get. So maybe that's not so practical. Gene therapy would be this one-off thing. So you could insert a gene that made something that reduced the complement pathway. So these are trials underway, and it would be just a once-off treatment. Again, you probably wouldn't start too early for an invasive vitreoretinal surgery where you put these genes under the retina. However, currently the trials require vitreoretinal surgery, and that's not so practical because they're not sitting around doing nothing. There's not enough of them, and there's not enough theatres. So they're trying to do gene therapy either via intravitreal injection or what's called a suprachoroidal approach. So not requiring an operating theatre and a vitreoretinal surgeon to do that. So that's all exciting. And then the other things are these stem cells. So can you replace the RPE that's missing with new RPE cells that you insert either as a suspension or you put them on a monolayer sort of scaffold and you insert that into the area that's missing. So that's also, that then potentially could bring back some vision that maybe has been lost. And the problem is that it possibly doesn't address the underlying cause. So once that little patch of RPE cells maybe lasts a bit longer, but all the others are still yours and they'll still degenerate. But there's certainly big jumps ahead in terms of strategies, not only looking at the complement pathway, but there's other strategies that may well work. And they're all really currently in early phase trials. So hopefully something will come from that.
What sort of stage of AMD is suitable for each of these trials? Are they all sort of targeting intermediate AMD or
so they're all late stage, particularly the ones that are interventions like surgery. But there are now our nanosecond laser, and there are other what are called short pulse lasers that are being used in an earlier stage. And also these red light photomodulation type treatments are beginning to have some traction. But one of the problems is it doesn't mean that these treatments won't work earlier. It's just how do you design a trial to prove that they work if you start early? So this is, again, work we work in this area, is how can you help industry plan a trial to prove that their drugs work when you start early? Because it takes such a long time to get to an endpoint. No one's interested to run that trial. So this is a big issue in AMD, and same with Alzheimer's disease. You sort of have to wait till it's too late to intervene to make the trial short enough, but it may well be far too late. And if you start too early, well, nothing's going to happen for years, and no drug company is going to want to run a 10-year study. So that's our major problem, is trying to find those earlier lines in the sand, like nascent geographic atrophy, where if you could stop that from happening, you would hope that eventually the regulatory authorities would agree that stopping nascent geographic atrophy is equivalent to stopping geographic atrophy. So then you could start earlier. But at the moment, the regulatory authorities are not there. They want to see a benefit to the patient, at least the Europeans do. They need to see that the patient got some better functional daily living criteria based on the intervention, and that's really hard if you start early. So it's not that the drugs won't work, it's either that we can't prove that they work if you start early, or it's so invasive that the risks would not outweigh the benefits.
Yeah. It does sound really challenging because, like you say, AMD just takes so long to progress that any sort of study would take so long to conduct. That's a lot of money.
That's right. But on the other hand, there's a lot of time to intervene. So once someone is diagnosed, you've got like a decade usually to do something, if only we knew what to do.
Yeah. And in terms of sending people who come to see your primary care clinician to support, what are sort of active resources at the moment that we can direct people to for AMD support, whether they're in their early stages or whether they're approaching their late stage?
I suppose the biggest support group is the Macular Degeneration Foundation, and so they're a great resource. So I would encourage people to contact them. And then every state has their own, Vision Australia for helping with low vision supports. So I think they would be the main ones when you're needing to see what devices there are. Vision Australia is great, and I'm sure there are other sort of private individual states would have different private providers of low vision aids, and Macular Degeneration Foundation does a very great job advocating for people with AMD politically and helping each other.
And are people able to find out where clinical trials are happening through that foundation website, or how do people find out?
So the Macular Degeneration Foundation say that they will send people in the direction of recruiting sites. It's part of their sort of now that they've decided that they will sort of help do that. I'm not sure how effective that is. It's a really great question because we struggle to find people with AMD to put into trials. It's a huge problem with trials that the time to recruit is a huge cost. And so we would love a system where we had a registry of everyone with intermediate AMD that we could call upon, and that's something I'm working quite hard to try and work out how to do that. But at the moment, you would have to know in your particular state who are the main trial recruiters, and they're pretty well known. I think if you read the journals, and certainly in Victoria, it would be the Centre for Eye Research Australia would be the main place that you would send someone. And yes, I would just encourage everyone that sees people and the patient seems to be interested to either find out more or maybe interested in a trial to try and find where they should be sent, because there's so much activity and Australia should be able to give the patients the benefit of going into these trials to potentially have treatments. But it really is it's a hard slog trying to find people.
That's so interesting, because I sort of imagine if you are looking for people, it would be sort of at the primary eye care level where an optometrist might see somebody for their vision condition, usually glasses, but then end up diagnosing macular degeneration. And from there, I suspect a simple question such as, would you like to be involved in a clinical trial? And then some sort of pathway to that would be...
Yes, you would think that would be simple, and to try and be allowed to put posters up in big chains. We've not been allowed to do that because once you introduce the concept of a research, then that will take time to talk to the patient and what that means, or I've got to refer you. So it's just that extra few minutes that it would require has been quite an impediment to try and get uptake in getting people sent. But as you started this whole conversation, that I've written quite a lot in all the journals, all the throwaway magazines, trying to indicate that there is an opportunity to send people for studies. So if this raises awareness of that would be great, because at the moment we've got staff going out to ophthalmology practice, looking through scans, trying to find people with drusen, because we are desperate to try and find these people for trials.
Optometrists have a huge opportunity here to not only contribute to macular degeneration research, but also potentially start their patients on some highly researched, perhaps not quite approved treatments just yet, but it at least gives people the option of accessing treatment which might stop the disease from progressing.
Yeah, this really is an opportunity for optometry. It really is to get involved in clinical trials. So we actually started a network, and we had, I think, 13 different optometry practices in Victoria helping us genotype patients for the first gene therapy study. And so that they upskilled, they did good clinical practice training, they learned to identify people with geographic atrophy, and then we would then take it from there. But they did do the genetic screening for us, and they were paid for their time. And to my mind, that's a wonderful collaboration. And if we can harness some sort of interested network of optometrists, then we would be very pleased to do that. So we did start a optometry network which worked well for the genetic testing, but at the moment we don't have studies where we can pay the optometrists for their time in referring those patients. But as far as I can see, you do have the ability to refer to the Macular Degeneration Foundation, and to me it should be just as easy to refer for a trial. And we've set up an oculo referral button so that rather than refer for treatment, you can refer for trials. So we're trying to make it easy. And from the Centre for Eye Research Australia, we've got a website where, as a clinician, you can also refer a patient, and also the patient can refer themselves. But then that requires us then to contact the optometrist to find some images to try and work out what stage of AMD they have. So yes, it's a work in progress to try and make that a much easier process.
Referring people with irreversible vision loss to clinical trials should be as second nature in practice as referring people to specialists for treatment, to the ophthalmologist for an anti-VEGF injection, or even back to, the GP for systemic investigations. So if it's not currently part of your clinical practice to do so, there'll be some links in the show notes to help you get started. Robyn, I'm so delighted that you were able to join us today to come to our recording and discuss macular degeneration with us. A lot of your life's work in ophthalmology, so we are so privileged to have had you here with us today. We've discussed what people with macular degeneration experience, how important it is, very, very important, as Robyn would like to drive home, that to classify the stage of disease so that not only the patient knows what stage of the journey that they're on, but to give us an idea of what treatments are available or might be available, and trying to get involved in clinical trials if possible, because ultimately that will lead to more potential treatments in the future for vision loss. Robyn, you've shared with us new treatment approaches, potential treatment approaches, and what we can expect in the near future. We've come such a long way because of a lot of the work that you've done since I graduated 20 years ago. So thank you so much for your work in this space, and thank you for coming on the show today.
An absolute pleasure. Thanks for having me.
Thanks for listening to Talking Eyes. Additional resources for this episode can be found in the show notes. If you found the content of our podcast interesting, feel free to post a great review and share it with your community. If you have a topic you'd like to hear more about, or have expertise in the field of vision and would like to contribute to future series, contact me via our socials on Facebook and Instagram. I'm Leanne Trin, your host of Talking Eyes.